SSRIs have effects other than increasing serotonin at the synapse. So they're obviously selective serotonin reuptake inhibitors. In the past, I believe in episodes on ADHD and OCD, we've talked about how they can also antagonize or upregulate sigma-1 activity, which has to do with parasympathetic tone, but they also alter the conversion of progestogenic metabolites.
But this summary, when I was looking at this, I thought to myself, thinking back to our episode on hypothalamic amenorrhea, that this really kind of puts to shame the guidelines we saw from the Endocrine Society. Were quite paltry by comparison, with very few studies referenced, and a lot of things that were had came out even prior to that publication were not mentioned in that paper.
Yeah, and as you would expect, most med students know, if there is a condition that's a mental health condition, or whether it's dysphoria or depression or anxiety, an SSRI is almost always the right answer. It might not be the root cause answer, but interestingly enough, and credit to our colleague Dan Bristow, Dr. Dan Bristow, for some of this info, SSRIs have effects other than increasing serotonin at the synapse. So they're obviously selective serotonin reuptake inhibitors. In the past, I believe in episodes on ADHD and OCD, we've talked about how they can also antagonize or upregulate sigma-1 activity, which has to do with parasympathetic tone, but they also alter the conversion of progestogenic metabolites.
Yeah, and it's not a one-way arrow in the way that they convert those. It sort of takes that, the pathologic state you were talking about earlier, where there's not that perfect balance at GABA-A. It takes that and normalizes this 3-alpha HSD enzyme. So some of the studies that have been done with this showed that individuals with really high levels of allopregnanolone return to the median. Individuals with lower baseline levels of this allopregnanolone also return to the median, have an increase. And I believe that was with sertraline. But it seems that they all have some efficacy in this. Fluoxetine has been studied pretty extensively. If I'm picking one of these, it's probably not going to be fluoxetine just because of the host of drug-drug interactions that are possible there. Probably going to pick something newer with slightly less interaction with other medications.
Yeah, I think that's a good summary of SSRIs. That being said, even though they're first on the list, it does not necessarily mean that they should be first on the list of treatment. A lot of SSRIs do have a withdrawal syndrome that can last about a week. It depends on which SSRI it is. For example, a SNRI like Effexor would probably be a terrible choice, especially if you're going to use it cyclically, because you'd have a terrible withdrawal each time you came off of it. Some people do take these throughout the month, but if they're taking something every day for a disorder that they only have a week's worth of symptoms for, it doesn't make as much sense. If someone's on no medications, then maybe fluoxetine or generic Prozac makes more sense because it has slightly less withdrawal because it has a lot of active metabolites. In the case if they're on no other medications or supplements or almost none. But it's certainly an individualized choice, much like a choice of an oral contraceptive for someone who wants an oral contraceptive. It's not a grab bag and you just pick a random SSRI and pick a random oral contraceptive because they're all the same.
Yeah, and you wouldn't necessarily do both of these things, but it is a kind of interesting take when you look at the mechanism by which the SSRI is improving things here. A patient would say, oh, I don't want to go on an SSRI. I want to treat the root cause. It's like, oh, so would you like to, stabilize your allopregnanolone signaling and take your high level of allopregnanolone to baseline? Yes. It's like, okay, well, an SSRI does that. It doesn't mean it's the only way to get that effect. But it's interesting that it does have some action that's very close to a root cause there, even though that's not the primary mechanism we think of with SSRIs.
Yeah. I guess one last note on SSRIs is later we'll note the various interactions between the progestogens and the androgens. For example, 5-alpha reductase enzyme has actions on androgens as well, converting testosterone to DHT. So SSRIs potentially have an interesting interaction with the androgenic pool as well.
Yeah, it's an exciting tease to our all things neurosteroid episode that we'll sit down and record. It'll be very granular, exciting for us, maybe less exciting for the listeners, but I'm excited to look at that.